So next, I would like to welcome Stevie Lewis and Dr. Mark Harrowitz, who are giving the first presentation this morning on coming off antidepressant medications and the importance of tapering. So brief introductions. Stevie is a patient advocate and Mark a clinical research fellow in psychiatry, and who have both campaigned for better recognition of antidepressant withdrawal and support for people in withdrawal. So their work has informed clinical guidance, including the recent NICE guidelines on safe tapering of psychiatric medications, including antidepressants. So I'm going to hand over to Stevie and Mark. Hopefully we may have some time for questions. If not, though, please feel free, if you have any questions for Stevie or Mark, to pop them in the chat and we will try and get round to them. Thank you. Thank you, Stevie. Thank you, Mark.
Thank you very much, Claire, and thank you so much to the AWTTC for inviting us to speak to you today. You will have heard from that short introduction there that Mark, who's going to speak to you after me, he's a scientist, an academic, a clinician, and then I'm none of those things. I'm retired, my degree was in European language, and my line of work was in the business world. But what Mark and I have in common is we were both patients, we were both prescribed an SSRI antidepressant, and we, like millions of others prescribed SSRIs, had no idea that we were taking a drug that we could become dependent on, and we could struggle with debilitating withdrawal symptoms. And that has brought us together into talking to people about this subject. I'm wondering, did any of you see the BBC Panorama programme on antidepressants on the 19th of June? They did an hour special on the subject, and if you did see it, you will recognise Mark from that. His story was covered, and the programme was about the extent of the damage that is done to people to some people by side effects and withdrawal effects of antidepressants. Now, what is significant about that programme is it came about really because of patient power. It's the voice of the patient that has been raised for a number of years now, because it's been clear to patients that there is a total mismatch between how doctors see antidepressants and believe in their safety and success, and the experience of many patients taking them. Now, looking at it from the doctor's perspective, the doctors were trained that antidepressant discontinuation is mild and self-limiting to about 2 weeks. So they don't see withdrawal. Now, patients found that that description of how to come off an antidepressant just isn't the case. And until last year, this is what the NICE guidelines said. So, of course, doctors are trained to follow these guidelines. So, mismatch. But patient power, through an all-party parliamentary group for prescribed drug dependence, persuaded Public Health England back in 2019 to look into this subject. And their report saw that what the patients were saying were true, and they recommended that the guidelines should be changed. We're in a situation where 1 in 6 people in the UK take an antidepressant. And so you will all know someone who does. And they're not just prescribed for depression, they are now the go-to drug for pain. Because, of course, as a country, we don't want to go down the same route as America with opioids. And so because there don't seem to be any effective treatments for pain, antidepressants now are what doctors are prescribing. So it's important to point out that research by Reed and Davies back in 2019 show us that 56% of people who take an antidepressant will experience withdrawal symptoms. So over half. You're more likely to have some withdrawal symptoms than not. And of that 56%, 46% of those will describe them as severe. So that means overall, a quarter of people taking an antidepressant may find that they have symptoms that they will consider disrupt their life in some ways and are severe. And that will happen irrespective of why an antidepressant was prescribed. Now, worryingly, doctors haven't caught up with the new NICE guidelines yet. They were only published in the middle of last year. So we're still in a situation where when a patient presents with withdrawal symptoms, what their doctor may well see is relapse or a worsening of the underlying condition. They still believe antidepressant discontinuation is mild and self-limiting up to 2 weeks. So we're at a stage where it's imperative that people understand what to do if they want to reduce or stop their antidepressant. And Mark is going to talk to you now about how to do that in order to keep your withdrawal to an absolute minimum, or maybe better still, not have any withdrawal symptoms at all. So at some point now or in the future, you may come across someone who needs to know this. And I know that some of you here are representing patient groups who you may want to consider passing this information on, because people with chronic illnesses, people with chronic illnesses, they're quite likely to have been put on an antidepressant, and they need to know what Mark is about to tell you. So please now allow me to pass you over to Dr. Mark Horowitz. Thank you very much.
Thanks, Stevie. Let me just share my screen. I can't talk without slides like Stevie. So probably cover a little bit of what Stevie's already said. Exactly as she said, the NICE guidelines in England for the last few years, until a couple of years ago, said discontinuation symptoms are usually mild and self-limiting. Along with that, the guidelines said that you can stop an antidepressant over 4 weeks. It actually turns out that advice, which has become law amongst doctors, was actually not based on any research. It wasn't based on a study. It was based on the consensus of the panel in the early 2000s. And we've learned quite a few things since then. Stevie's talked about doctors not seeing withdrawal effects because, like in my training in medical school and as a psychiatrist, we were taught a lot about relapse, return of people's condition, and we didn't hear very much about withdrawal effects. The consequence of that is there are hundreds of thousands of people who go to online websites to get advice on how to come off their antidepressants. And their story goes something like this: my GP or psychiatrist told me I could stop my antidepressant over a few weeks. The effects were so horrendous, I had to go back on them. The doctor told me there shouldn't be a problem with coming off them, so it must be my original condition coming back. Diagnosed me with relapse and informed me I should probably be on this drug lifelong. But it felt different to me in a variety of different ways. I felt dizziness, I had brain zaps, I had panic attacks for the first time, and so I've now lost faith in my doctor. The advice on these websites, these are websites, both American websites, was more helpful than my doctor's website, my doctor's advice, and coming off them much more slowly, my antidepressants, has made the process much easier, although still not easy. 1 in 6 people on these websites are from England. I don't know the stats for Wales, sorry. So just very briefly, what are antidepressant withdrawal symptoms? It's a collection of psychological and physical symptoms that occur on stopping or reducing the dose of an antidepressant. It occurs because of the changes in the brain caused by antidepressant use. So the brain adapts to antidepressant use in the same way that we adapt to, if it's too hot outside, our body cools down. If it's too cold outside, our body warms up. The brain adapts to the drugs, and it doesn't just snap back into its pre-drug state. It takes a while to get used to the drugs not being there, and that's what explains withdrawal effects. There's often a mix-up between physical dependence and addiction. Antidepressants are not addictive. People aren't craving them. There's not compulsion. But physical dependence, well, that word is often used interchangeably with addiction, actually refers to that adaptation to a drug that occurs over time. It doesn't involve misuse or abuse. It doesn't require a drug to be euphoric. It's just what happens when you use a drug that affects the brain repeatedly. There are lots of different symptoms of withdrawal because these drugs affect so many different parts of the body. There's dizziness, there's trouble sleeping, impaired concentration and fatigue. There are mood symptoms like depressed mood, irritability, anxiety, panic attacks. There are sensory symptoms. Electric shock sensations or brain zaps are a bit famous because they're so strange. There are gut symptoms, and there's even an increase in suicide attempts in the 2 weeks after stopping an antidepressant that's been attributed to withdrawal effects and not to relapse because it's too soon for that to happen. Misdiagnosis by doctors, it's a huge issue. It hasn't been studied in detail. We did a survey of 1,400 patients, 1 in 6 of whom were from England, who said that the reason that they had gone and sought advice on websites was because their doctors had misdiagnosed them as relapsing rather than having withdrawal effects. It's very easy to understand why that happens, because withdrawal symptoms can involve anxiety, depressed mood, insomnia. We know that because even people without mental health conditions who have never had these symptoms before can have them for the first time in their lives on stopping. When people turn up to GP offices complaining of these issues, it's very easy for doctors to jump to the conclusion that it must be a return of depression or anxiety, especially, as Stevie pointed out, when the guidelines have said for years that withdrawal effects are only mild and brief. There's a few ways to distinguish withdrawal from relapse. They come on quickly after stopping. There are these specific symptoms like dizziness and so forth that I've mentioned, and they often go away quickly when antidepressants are restarted, but doctors aren't well trained in making that distinction. There was a lot of research that Stevie referred to over the last few years, which led to changes in the official guidelines in England. So the Royal College of Psychiatrists actually went on TV to say that people should be informed of severe and long-lasting withdrawal symptoms after stopping antidepressants. And NICE also updated its guidelines based on new research to say withdrawal symptoms can last for weeks and sometimes months. And we know that it can also be years and can be severe, especially when stopped too quickly. So I wanted to talk about how to avoid withdrawal symptoms. If that's the issue, how do we try to avoid that? The Royal College of Psychiatrists in 2020 put out some guidance on how best to come off antidepressants. But I wanted just to talk through, if you take one thing from this talk, it would be to go to this guidance to get some advice on how to come off. This guidance advises a few broad principles. One, people who've been on the drugs for more than a few weeks should take months or longer, sometimes years, to come off the drugs. Some people will need to go down to very tiny doses, less than 1 milligram, before stopping, much lower than normally used doses, or even lower than you can make with tablets available at most pharmacies. They recommend going down in smaller and smaller size reductions. And importantly, the rate of taper should be adjusted to what the person can tolerate. I'll make sense of where some of this advice comes from. We did some work a few years ago, published in the Lancet Psychiatry, on how these drugs affect the brain. So I'll walk you through the slightly technical part of my talk. This is a very common antidepressant, citalopram. On the y-axis is effect on the brain. It happens to be inhibition of the serotonin transporter, the main target of this drug. But you can think of it as just an effect on the brain. And the main point is the relationship's not a straight line, but a curve called a hyperbola. Very small doses of the drug have much larger effects than you would expect. So the most common doses prescribed in practice are 20 milligrams and 40 milligrams. But in fact, 2 milligrams of the drug has almost half the effect of 40 milligrams. And the reason for that is when there's not much drug about in the body, all of the receptors that the drug affects are open for business, unsaturated. And when more and more of the drug is in the system, more of those receptors are full of other drug. And so every extra milligram of drug has less and less effect. This is sort of the law of diminishing returns. And that tells us what happens when doctors advise what they mostly advise. They advise going down by what I describe as a linear reduction scheme. So going from 20 milligrams to 15 to 10 to 5 to 0. It seems intuitively to make sense. It's easy to do with tablets. You can just halve and quarter them. But in terms of effect on the brain, the first reduction has a very small effect. The next reduction has a slightly larger effect, larger again. But the final reduction from 5 to 0 actually has about 20 times the effect of the first reduction from 20 to 15. And that's exactly what patients report. The first few milligrams are fairly easy to come off. The last few milligrams are excruciating. And often what happens at that point is the doctor or sometimes the patient concludes, well, they must need that drug because they've had such a hard time coming off it. Understanding this relationship, though, allows us to understand what would be a more rational way to come off the drugs. So in this case, I've drawn it so that there are changes, that there are linear changes in effect on the brain. So I've drawn lines at 20 percentage points. And what that requires is smaller and smaller size reductions in dose down to very tiny final doses before stopping. So that final reduction from, in this case, 0.8 milligrams, a very small dose to 0, doesn't cause a larger change in effect as those previous reductions. In other words, it's a little bit like walking down a shallowly inclined plane or hill that then turns into a very steep cliff. And so you need to go down much more slowly at the end to avoid falling off that cliff. And so the guidance that I showed you from the Royal College of Psychiatrists follows those principles. And for example, it's for citalopram, the example I've just given, it recommends going down by smaller and smaller amounts, down to very tiny doses, 0.6 milligrams before stopping. And you can see that they're advising using a liquid version of the drug to make that possible. That was an example for citalopram. Other drugs are even harder to come off, like paroxetine. And in this case, they recommend going down by even smaller amounts, by 10% of the most recent dose. So going from, say, 40 to 36 milligrams to start with. By the time you're down to around 20 milligrams, the reductions are even smaller, about 2 milligrams, because the percentage of the most recent dose is smaller. That can take people a long time. I run a clinic that helps people to come off antidepressants, and it's not unusual to see people who take 2 years or 3 years to come off paroxetine because it's so unpleasant to reduce. And again, going down to a very small final dose before stopping. The Royal College guidance reiterates it's important that the rate is guided by what the patient can tolerate. It's very hard to just say, here are some doses that you should follow. It's a much more involved process than that. You've got to monitor how patients respond to the process. If withdrawal symptoms become too severe, you should slow things down or reverse, and then go at a slower pace. And some people can only reduce at 10% of their most recent dose every month, which means the reductions get smaller and smaller. It can take quite a while. The NICE guidelines now adopts this also as their official guidelines. It's not very, NICE guidelines are a little bit like the 10 Commandments given from on high, because they use very brief language to explain complicated processes. So I'm not sure that this guidance is clear enough for any doctor to make sense of, but it says slowly reduce the dose by a proportion of the previous dose. So they're referring to those graphs that I showed you before, but in a very kind of brief way. They recommend using liquid preparations of the drug at smaller doses. They emphasize the rate should be dependent on what the person can tolerate. And they also try to set expectations that it can take months to come off these drugs. And we know it can take years. The NICE guidelines actually links to the Royal College guidelines. So we hope that doctors may read them, and they've got a bit more detail than the NICE guidelines. People generally ask me, how do you make up these small doses that you get to? Because it does present a problem for doctors. I think this is where pharmacists can be very helpful. Most of the tablets that are available in England are too large to make the sort of reductions that have been outlined. A lot of antidepressants come as a liquid in England. There are other options. You can compound medication. And then the last message is a lot of doctors also skip doses. They sort of know that they want to try to make up smaller doses every day, and they do that by giving us a dose every second day. The problem with that is it causes wildly up and down levels of the drug in people's systems. And so it's better to give a small dose every day than every second day. The only drug that there's an exception for is Prozac or fluoxetine, which has a longer half-life. And I'll leave it there. Thanks very much. Happy to answer any questions if there's a bit of time.